now that we are done with all the presentations, I think we are now into the panel discussion and Q&A time. I would still encourage people to post questions. We right now have only a couple of questions that have been posted. So while we wait for more questions, let me kick off the discussion with a few questions to our panelists. Like I promised to introduce, we have with us 4 panelists. Dr. Aldiana Halim from Indonesia. It'll be good if you can have your videos on and as spotted. Yeah, he's from the premier and the largest standalone, I think the only standalone eye hospital in the government of Indonesia in Bandung, which I had the good fortune of visiting several times, and know it's an exceptional institution, and he is from there in the research department. And we have my good friend Inayat Hussain from Bangladesh, a well-known pediatric ophthalmologist, and also been part of the Ministry of Health, directing healthcare in general in Bangladesh. So I'm hoping that he will bring us a lot more integrated perspective, to this whole discussion, because many of us are kind of enclosed within ophthalmology. And we also have Dr. Praveen Vashisht from the Premier Institute in India, the RP Center, part of the AIMS. He heads the community eye health department and has been extremely active in many fronts, conducting over 30 odd RAPs across India, doing resource mapping, and been a rich resource for eye care in India. And then we have Shailesh Mishra, who again plays an important role in eye care in Nepal as the executive head of Nepal Netra Jyoti Sangh, which essentially coordinates most of the, I won't say all, but most of the NGO eye hospitals in Nepal, and they are the ones who provide possibly close to 80 to 90% of all eye care in Nepal. So we have an excellent panel, to kind of go deeper into this topic. To start with, I'll pose a question. I have a question for each of the presentation, which I'll pose to the panelists. And then it will be good to also hear from the speaker's perspective as well. So with respect to the very first presentation on the overview of the IPCEC, I wanted to take a slightly different perspective to what Rohit had presented. Now, he mentioned risk factors and listed several that are modifiable and non-modifiable. However, you would recognize that he related all of them to the patient and the community, like age and lifestyle and so on. So in my thinking, I thought we should also recognize there's a parallel list of factors, that are provider-centric, not from the patient side, but from the provider side, which I think they are the ones which really lead to disparities, low coverage, and suboptimal outcomes. Because quality is largely in our hands. So these could be risk factors in one way of looking at it, not in a technical way. And they could be around design, how the care is designed and delivered. Now, how is it made available? How is it made? How is the financing done, for this care? All of these are provider side factors, policies. So I just want to kind of throw it to the panelists to see how do we address this in the context of integrated people-centered eye care. So anyone can jump in. And at the end, I would like Rohit for you to round off. Yeah.
Okay.
Yes, Shailesh.
Yeah, thank you very much, Tulsi, for a very good, I think, issues, the risk factor. I think, yeah, you have already mentioned that the risk factor could be around the design, the resource availability, and other risk factor as well. And I agree that there are several factors at the provider ends that from the provider ends that lead to these disparities and low coverage and suboptimal outcomes as well. First, the good design of the eye care program is very important in every steps. For example, we do the outreach program, outreach activities in the community level, but we are not following the strategic pillar of the sustainable outreach program in many places, like for example, the calculating the magnitude of blindness there locally from the different surveys, and fixing the targets and the plans, resource management, community participation, community engagement, following the protocols, and calculating the case finding cost. After that, the fixing the parameters and benchmarks. In this way, another issues like while opening the vision center or the community eye care center or the primary eye care center, whatever we call it, we have to be evidence based. We have to identify like where is the unmet needs, where is the vulnerable groups, size of the surroundings population, accessibility of this eye care center, we have to identify how we can close the referral and treatment loops. So design plays an important role to address this disparity as well, because if we have a good design, many patients can have the accessibility. And also there is no tracking system of the referral patients to the secondary or tertiary eye hospital in many countries. We have seen that has also to be addressed. Apart from that, we have to create a shared vision aligning with the team. We have to also see the underutilization of the resources. Regarding the financing, we have to avail the rural insurance system, or in Nepal we have the social security national health financing that can pull the risk as well. And for the human resource as well, we have to build a accountable team. We have to identify the population need as well, the quality of the training, and the policy and regulation, that is internal and external, is very important. I have seen that in many eye hospital, the management are not aware that the hospital should be disabled friendly, or there should be the female friendly environment in the hospital. So all these things, and market development, segmentation, these all things we have to put in focus, put in ahead to lower the disparities, low coverage, and some optimal outcomes.
Thank you, Sailesh. I think you really pushed the case for denominator-oriented planning and also patient-centric kind of approaches. Yeah, any other reflections on this, Inayat, Aldiana, or Praveen?
Yes. Thank you.
Yes, Inayat.
Yes, please. Thank you, Dr. Khanna, for your nice presentation, cover all these things. So I'd like to mention something in the perspectives of Bangladesh. So basically, there should be strong government's political commitment should be there. In the country, we have for the eye care, there is an operation plan. It's indicate that government has strong political commitment for this one. And regarding policy formulation, I broadly point out the four things that should be covered for the ensure the IPC. One thing, we should cover that eye health should be in all policy and whole society approach. This should be done. I'm just talking about the broad headings. Another issue is that when we're designing our policy and formulating one, social determinant factor of the health should be addressed. Third issue is that regarding the concern of SDG, we must think of the leaving no one behind. Otherwise, we will not ensure the universal health coverage. And third thing, there should be the primary eye care should be integrated part of the primary health care. Other things I should mention regarding the financing. Financing should be appropriate, and it should be both from the government side, and also we should pull the money from the donor agencies and from the international agencies. And utilization of financing, key issue is the equity issues. In Bangladesh, actually, in the government service, the public health facilities, we did not ensure till now the equity. It is equal for all. And some other private hospital also, they do not ensure the equity. So not only the budget utilization, budget allocation, but proper utilization should be there as needed. Designing a phase, it should be community oriented. Community people should be well enough oriented. They should be know their health need and they come to the facilities and like this. And there should be the proper monitoring of the quality care. So these are for the our government side. Thank you very much.
Thank you, Inayat. Thank you.
Yeah.
Anyone else want to jump
Yes.
in, or
Yes.
otherwise I would request Rohit to jump in. Yes, Aldiana, you have something
Yes,
to say.
yeah. So one of the most challenging part in implementing integrated people-centered eye care is to encourage, at least in Indonesia, to encourage the policymakers to integrate the eye care into the health system. Even though the epidemiological evidence of visual impairment is available in some point, that the eye care is still a limited progression because of limited resources in the country health system, and it has to compete also with the other health demand. We are not talking about in the national level because the eye care program should be implemented in the a smaller area, like in the district level of the health system. So yeah, we have still a problem to integrate in the area of the province or in district levels. I think one of the easy way for policymaker to understand the problem of the visual impairment in the area is to convert or to analyze the economic impact. Sometimes when we provide the policymaker, especially in district level, that we have a problem that the policymaker is not familiar with the technical methodologies or with the complex implementation level in implementation level. So we are thinking how to. We are thinking also we have to include into the consideration to provide a way for the eye care activists, especially in province and district level, to also to analyze maybe in the simple way how the visual impairment impact the economic, because it's an easy way to deliver to the policymaker and to integrate the eye care program in the district health system.
Thank you.
Sir, I would like to mention few facts about India also, like key challenges in our country. It's mainly, even after all possible approach by government, still it is considered as a vertical program. And as far as the vision centers and primary eye care is concerned, there's some good initiative have been taken by the NGO sectors and also some private hospitals. But as far as the government of India is considered, there is definitely there is more need for integrating this private NGO sector with the government sector. As I can give an example, in 2004, when Vision 2020 India launched, and at that time we aimed that we should have 20,000 vision centers in India, and even now we say this around 4,000 vision centers. Clearly, lack in approach. Though we plan quite good, but in terms of implementation, we find such error difficulties. And of course, there is lack of coordination. As far as workforce is concerned, I believe the number of ophthalmologists is quite good. They're trained also. But here is main deficiency is in terms of paramedical, ophthalmic assistant, and optometrist. The huge lacunae of such human resource. And because of this, this refractive error program is being affected in our country. And we believe we have hardly 20% coverage against this, what we are thinking for universal eye health coverage for a country by 2030. Thank you.
Thank you, Praveen. Very quickly, can you respond, Rohit, because you have thought a lot about this particular topic?
Yeah, I think what everybody pointed out, first coming to Tulsiraj, your question, actually, what you said was like very right. It's like we look from the patient side, but we don't look from the provider side. But most of the provider side also comes as a barriers to eye care, like poor surgery or poor outcome or distance or lack of, so they are to some extent covered in the barriers. But I think but that's true. There are also modifiable and non-modifiable factors in both provider and patient side. So what coming to, I was just making notes of what Sailesh pointed out was, as you rightly said, it's very, he was looking at the denominator-oriented approach for providing integrated people-centered eye care. And I think what Praveen said was like basically lack of human resource and even considering eye care as a vertical program. So I think we have to define what does integration mean. I think we ourselves have to be clear. Yeah. What do we integrate? Where do we integrate? Where do we draw the boundary line? We cannot start into one specialty completely, jump from one specialty to other specialty. So where is our boundary line at primary level, secondary level, tertiary level? So that if we have that document, this is what we say and go to the government or policy makers. This is a document which we can say that eye care will be supporting, will be integrating at each level of care in this manner. And probably the same thing should come from the other sectors also. So that would be something which I think we should come up with that guidelines rather than waiting for government to give a write a statement and say that eye care is integrated. That will not help us anyway. The moment we say the government announces that eye care is integral part of healthcare system. So then what next? So what do we do at primary levels? What do we do at secondary levels? Probably I think that is something which we need to come up with solution.
Sure.
Because we came up with solution for all our problems in the past. So we should come up with the solution also.
Yeah. Thanks, Rohit. Thanks, Rohit. I think I'd like to switch gears now. And I don't know, Russell, is it possible to highlight Dr. Sripriya? Because I think the next few minutes would be centered around her presentation.
Yes, we'll get her spotlight for you.
Possible. Yeah. So I'll pose the question to the panelists. Again, feel free to jump in, anyone. So Dr. Sripriya, like I said earlier, possibly took the most comprehensive perspective to quality. She touched upon a lot of neglected elements like engaging people and communities, as well as coordination across sectors. So in all this, we recognize that quality is always a journey. It is not a goalpost. We continually, it's a direction basically. My question is, so there are some areas that we are not very familiar with, in the much bigger quality framework that Dr. Sripriya touched upon, things like community engagement, intersectoral coordination. So these are areas that we mention it, but then we're not very familiar with it. So my question to the enlightened panelists is that, how do we foster this? How do we make this happen? How do we make better community engagement and coordination happen? I'm sure within your own selves, you would have experience doing it. So I thought it'd be good to hear from you. And as in the past, I would like Dr. Sripriya to kind of give some closing comments at the end. Yeah. Yes, Shailesh. Yeah.
Yeah, thank you. I think this we already know that this maintaining quality in community eye care is not just confined to delivering the best visual outcomes, but implies a lot of more aspects of the eye care services, and there are like different types of activities which can increase the quality of eye care services, and the community engagement as you have already mentioned, and the intersectoral coordination can play a great role for the same. So like for health sector in eye care to be truly people-centered, this first thing we have to know that the service users and the communities need to play an active role in the design and delivery of the healthcare services to ensure the local needs. So there should be the regular like kind of patient provider interaction that is very important, which can affect I think which can increase the quality of the eye care services as well. And the eye care professionals that are working in the community should always understand and take account of the community cultures. That is their perceptions, their experiences, their expectations in their interaction with the service users and the families. That can be the real reasons and the concerns that will influence the prevention, promotion, and treatment decisions as well. And ultimately, that will increase the quality of eye care services. And third one is the monitoring and evaluation framework, with the relevant indicators used for the strategic decision making. So like in Nepal, we are doing the social auditing of the program of the hospital, of the eye care center as well, or the community people provide the feedback on the quality as well. So like we have to develop the ability at the community level to effectively combine the wisdom, knowledge, and concern of all those involved in the community, so that we can achieve like a greater and more sustainable process of continuous quality improvement. And forming partnership is very important to share the resources. In Nepal, we have formed the partnership with the local government in many cases to establish the eye care center, and the people are getting their services at the local government, like the local government level as well. And we have to encourage the dialogue about the community concerns as well. So like there are a lot of activities we can start with the help of community engagement, which will ultimately improve the quality of eye care services, creating the awareness, planning and management of the sustainable and equitable eye care services, dissemination of information, social marketing, integration of the key components in the school child screening program, community-based rehabilitation program, primary eye care, training of primary health center. In Uganda itself, like there is the eye care facilities which is governed by the health unit management committee, and which have the community members directly contributing to the facility management, and that is like they have been empowered to co-design the quality improvement as well. So like there are a lot of activities with the help of community engagement and intersectoral coordination. We can ultimately improve the quality of eye care services. Thank you.
Thank you. Inayat, I think you wanted to say something.
Yes. Thank you, sir. Again, it's a very nice presentation. So I like to mention here that from the beneficiary side, they should ensure the health literacy. If there is a health literacy, they are to be fine. So we have the very good program of immunization. So the community service provider, they will have the twice a week visit to the villages where they arrange the courtyard visited. We call it the Uthan Boitok. So courtyard, that's why they ensure the health literacy of our beneficiaries. This is the one way. If we can integrate the eye care, it's not yet to integrated eye care there, so that will be one issue. So at the community level, again, we have the very good experience involving our local political leaders. When they are engaging the programs, they will ensure they know which people they are suffering from and others. So they will refer the patient to the nearby facilities. In the NGO sector, we have a good experience in the Bangladesh Diabetic Association. So they are now involving our religious leader in every mosque in the Friday. They will ensure the diabetic screening camp, and we manage them to make the beneficiaries to refer to our nearby Upazila hospital. They have the eye care check-in, eye check as part of their diabetes program. So this is one way if you involve the religious leaders. During presentation, I have 2 or 3 observations. One thing is that how we address the multi-disability. So patient with eye disability and the other disability, how we ensure service, or the patient with other disability, how they will be ensure service. That is the one area which should be ensured to ensure the universal health coverage. Other area is that though it is very limited, but we should reduce the out-of-pocket expenditure. We find out reduce the out-of-pocket, how to minimize the out-of-pocket, reduce the out-of-pocket expenditure. I'll share 2 experience of our integration. In our ROP retinopathy of prematurity program, so it is led by the National Newborn Health Program. So I am the advisor of this program, but led by the National Newborn Health Program. So they are ruling it. Again, we are able to, in our IMC, Integrated Childhood Management Program, we enable to incorporate the eye care. So now earlier it was not, eye care is not there. Now at our Upazila hospital, this sub-district hospital, IMC center was there, and the service provider, those who are the paramedics and other, ask the patient, they have the eye problems and other, so that we can skin the cataract and the squint portion from the early part of their life. So these are our experience I'm sharing. Again, very good presentation, I think. Thank you very much.
So in the interest of time, can I request Sri Priya to say a few words, and then we move on to the next topic?
I think Dr. Shailesh and Inayat summarized the entire thing of how quality care has to be incorporated. To create quality care, we need to incorporate the community into the existing healthcare system, and we need to integrate the government with the politicians, with the religious centers, and with the NGOs. Unless it's a continuum, quality eye care cannot be delivered. That is from the delivery viewpoint. And we need to integrate our data entry has to be integrated with the health ministry, so that there is a the work that is done at the community level is reflected to the government, and it will facilitate the policy makers to decide on how to change the policy and evolve as we go.
Yeah. Thank you. Thank you. I think in this space, we have a lot of work to do. I think we have the ideas, we have some proof of concept, but I think we'll need to make it more structured, as well as figure out how to scale this. Yeah. So I would like to switch gears, and if Divya can be spotlighted along with others. We all have gone now. Yeah. So what I want to ask the panelists is, I think in her presentation, she kind of proposed 2 important aspects. I think for the first time in eye care, when we operate at primary level, we really can design a denominator-driven eye care, based on needs, which Shailesh also mentioned earlier. Establish the needs for that community, and then see where we are, 20%, 40%. So we can really be evidence-driven towards coverage. And then also it makes it clear as to which are all the areas wherein we can do the integration. Because it becomes much more real at that level. So my question, very briefly to the panelists to think about is, now that we have this knowledge, how can we leverage this to kind of both to scale, towards achieving universal eye health as well as the goals of the SDGs. So briefly, Shailesh, if you can respond to this. I know you had some preparation done. If you can be brief about it, then I'd like to hear about from Aldiana as well, from Indonesia.
Yeah, thank you, sir. I think just right from the presentation of Divya, we came to know that the primary eye care that is provided by the Vision Center in Nepal, we call Community Eye Care Center, or the Primary Eye Care Center, or the Eye Care Center. That is the essential the block for the prevention of blindness in all the communities. And without this primary eye care, only those individuals who present to the secondary and tertiary facilities will be diagnosed and treated, and little will be achieved in terms of prevention. However, we know that the scope of this primary eye care varies significantly throughout the regions. Like if you go to Africa, then is primary health workers are providing the primary eye care. If you go to UK, USA, and Australia, that is a developed country, the primary eye care is provided by the specialized personnel such as optometrists who are independent eye care service providers in these countries. In countries such as in India and in Nepal, in the government sector in India, the primary eye care is provided by the trained paramedical ophthalmic personnel, and in Nepal, the primary eye care is provided by the ophthalmic assistant. That is that we call the backbone of the eye care services in Nepal. And sometimes we call them the vision technicians as well in India. But this combined effort is very important, both for the vision center and the base on the referral hospital to reduce the load of visual acuity. But these vision center, what we are talking about, or the primary eye care center or the eye care center, is like a static kind of things. In some areas, like in India, in some hospital, and in Nepal as well, of course, they are proactive, but these vision centers which we are establishing need to be proactive rather than reactive. Hence, like a deeper development and some rethinking of the model of this vision center need to be, I think that has to be remodeled to achieve this, to scale up the eye care services. So like some kind of innovative models of eye care can be introduced at the primary level, as per the local situation and the general healthcare system as well. But we all know that the integration of eye care into the primary health care is very important, but that has also raised some passionate debates in many places, like in where the public health care system is very weak, under-resourced, and inefficient. So nevertheless, there is the evidence that the integration of eye care at the primary healthcare can be effective through enhanced supervision and training of primary healthcare. It should be effective, and it will be effective. So there are a lot of strategy. But if we have a good primary eye care program in the country in line with integrated people-centered eye care, first there should be the good community participation, like we have seen in example in Nepal. As primary eye care, the vision center are locally based and have important links to the community. There is a scope of involving community members, like in health promotion, applying social marketing strategy for the behavioral change for the underserved and marginalized population. That is very important. We have to create the demand for that sector as well, and the announcement of special services. Like in these all things, community participation play a very good role, and reorientation of the model, that is which is integrated, and there is a referral pathway, that is very important. We have also seen some examples of training of female community health volunteers, Anganwadi workers in Nepal and India, and there are some eye hospital where we have mobilized the field worker who take vision in the community, as well as there is a door-to-door screening in some districts as well in Nepal. And also the using the technology is very important, like teleophthalmology, which has been used in India, can be replicated in the other countries as well. Like after that, the information technology, like the regular mobile text messages to strengthen the communication between the eye care patient and providers. That is the additional ways to be introduced. And integrated services into the government healthcare system is very important. Intersectoral collaboration at the community level with the schools and the NCD program is also very important. And this for the long-term funding sustainability, that can be, we can have the coordination with the local government that can be funded for the operating cost of vision center or the eye care center or the primary eye care center for the long-term sustainability. So the concept of this integrated people-centered eye care as promoted in the World Report on Vision, that through some changes in the model and replicating the successful model can ensure the eye health services to reach those who need the services the most. So in this way, we can scale up these eye care center and vision center.
Thanks, Shailesh. Yeah. So in the interest of time, I think we just have less than 10 minutes now, 8 minutes before we have to come to a hard stop. So let me take one question from the audience as well, which is sort of related to this particular topic. I think Sonia Mavi has asked, how do we, when a woman accesses service, her concern is, how do we know they're receiving effective eye care? For example, she says, women access refractive services but do not receive spectacles due to whatever, cultural, financial, other barriers. Now, how do we deal with this? So Divya, Aldiana, if you have some insights, you may want to talk about this.
Yes, I think that's problem how we provide the services for the people in need is also the problem here in Indonesia. Indonesia has many islands and has a dispersed population. So we are talking about the people in the rural area, in the islands that who hard to access the eye care services. So we create some model of the service delivery in eye care, like in refractive error. So we are now start to implement to provide the ready-made glasses for the people in the rural or in the island for the spectacle, for example. And we have tried and we have researched the quality of life and the compliance for the school children, for example, in the rural area is good. So we are now start to implement how to share ready-made spectacle, especially for the people in the remote area. When we have still the problem to deliver the cataract surgery services. So we in remote areas, so we are now in Ministry of Health of Indonesia design like it's not a fiction center, we call it a cataract center because the need of the cataract is so big here in Indonesia. So we are built a cataract center in the area for approximately 30,000 people. So create there and the services is mobile in one district, mobile in to 4 cataract center, and it operate one month in 1 week in a month. So we in whole month we can cover the whole district, I think.
Thank you. There's another question from Daniel Shainholz asking, can vision rehabilitation be integrated into implementation of the SDG goals? And would it be optimal at primary, secondary, or tertiary level? It's kind of a design question. And I'm presuming by vision rehab, I think he is referring to more low vision services. So what do you think would be feasible at primary, secondary, and tertiary level? Yeah.
I'm responding it.
Yeah.
Yes, thank you very much. Actually, I earlier mentioned that this is a common problem where the patient with disability, multi-disability or disability, how to address that. So actually, it is not possible to have the low vision service diagnosis and other things in the primary level. So I think it should be somehow in the tertiary level or at least in the secondary level. But the regular periodic checkups and the equipments and other things, they should be ensured. It should be their doorsteps, I think.
Yeah. So I think this is where the integration really comes in. I think certainly at the primary level, you can do case finding, identify people who would benefit from rehab. Now, while the rehab itself would happen in tertiary level, because of low numbers and the expertise required. Again, the compliance and follow through can again go to secondary or tertiary level. So I think this is a beautiful case where integration can help a lot. And before we wind up, we have another 3 minutes. I just want to briefly touch upon the monitoring, where Dr. Rachna Mil talked about the revised thresholds for the cataract and refractive errors, where the threshold is now brought down to 612. So I just want to very quickly check with the panelists. Now, how do we operationalize this? Because till now we have been very used to referring patients either at finger counting or 3/60 for cataract surgery, to referring people who are below 612. So how do we engineer this kind of? It almost seems like a mind shift change. How do we make this happen?
I'm responding one. Actually, I do not know whether this is ambitious was not, but I am thinking of this, the people, the living now behind who are not coming to our facilities. I'm thinking that there should be a trained community health worker. They should visit house to house. And from there, they should, with the laptops and other things, they should capture the data, those who are in need of, and ensure their presence at the primary centers. And that ensuring should be with the community leaders or others, those who have needed facilities. Maybe they have the other accessibility issues that should be addressed. And by this way, we ensure them to be in the primary healthcare centers. And there will be the process level intervention should be at the low cost and high impact and the good quality ones. If you go for the output level, so output level, the coverage will be, we ensure the more. So these are the way we can ensure it. Thank you very much.
Any last few words, Dr. Rachna, literally 20-30 seconds before we wrap up.
Yes, so indicators, I think, are very difficult to set up for this kind of an integrated service, because we need to see, we need to actually monitor the input as well as the output, and we have to make indicators accordingly. And like, for example, the ones that I had put in the presentation, the ones that are already used in UHC, Universal Health Coverage, to assess universal health coverage, where they see the prevalence of the unmet need of refraction and cataract, and then of course they see the prevalence of the met need in terms of quality, where they say what is the vision of the patients who've got refractive correction or cataract surgery. So similar ones need to be developed for other areas of glaucoma and also diabetic retinopathy, and I'm sure they'll come up, but it will need more deliberation because they are not as easy to measure as maybe an outcome of cataract surgery or refractive correction. So it needs more deliberation by the people involved in the integration.
Good, right. Good. Thank you. I think that's a good way of also summarizing this workshop, because I think the true learning happens when we have lots of unanswered questions. And that's precisely what this deliberation for 90 minutes has come up. I think at one level, rich content was brought in. And I think the content itself challenged us on many fronts on what needs to be done. So I think we're on a journey, and I also believe we're on the right path in kind of discovering and codifying what integrated people-centered eye care should be. And I think deliberations of this kind, going back and reflecting on it and then coming back in other forums, I think is what will lead us to in that direction. And I'm sure each one of us, both at institution level, at national level, policies like Dr. Inayat is positioned to do, to kind of bring in this understanding into practice and policies. I think will happen, and hopefully in the coming times, we would have better insight and deeper understanding of really making this integrated people-centered eye care a reality. So I want to thank the 4 excellent presentations, the presenters, as well as the deep insights that came clearly from experience, that was shared by the panelists, and also for the various participants for raising some of the questions. I know some got answered offline, but again, we want to thank you for your participation. Thank you all.